Hi, everyone. Again, my name is Quintin Solano. I'm presenting on behalf of Mary Shen, who's a PGY4, cannot be with us today. She's a surgical resident in Michigan Medicine. I'm a third-year medical student, as I said earlier, at Michigan Medical School, and I want to thank the wonderful team and SAGES for allowing us to present our work on ventral hernia mesh use in females of childbearing age. These are our disclosures. Up to 1 in 4 ventral incisional hernia repairs are performed in females of childbearing age. There's a lack of agreement amongst experts in the field of how to repair ventral hernias within this population. Recent qualitative work suggests that the attitudes and beliefs around the population are heterogeneous amongst experts. And while mesh repair significantly reduces the risk of hernia recurrence, there is evidence to suggest that suture repair may be more appropriate given the anatomic and physiologic changes associated with pregnancy. Current evidence suggests that ventral hernia repairs in females may be best deferred until completion of all pregnancies. Most recently, the European Hernia Society and the American Hernia Society have recommended suture repair in women of childbearing age if the hernia is symptomatic, if not, waiting until after the last pregnancy to repair the hernia. However, whether or not these practices in the general population reflect the guidelines remains unknown. So within this context, we ask at the population level, does mesh use vary by age in females? And what factors are associated with mesh use in this population? We analyzed adult females undergoing ventral hernia repair using a population-level clinically nuanced hernia-rich data set, the Michigan Surgical Quality Collaborative Hernia Registry, that collects detailed hernia-specific variables such as hernia size and location and mesh use and type. Our main analysis included females aged 18 to 44, and the secondary analysis included females of all ages. The primary outcome of this study was mesh use, which is a variable that is abstracted directly from the operative report itself. Patient data included in this analysis were patient demographics, comorbidities, and hernia and operative characteristics. Our main analysis consisted of a multivariable logistic regression to estimate the association of patient, clinical, and hernia-specific variables with mesh use among females of childbearing age. We also performed a secondary analysis to estimate the association of all variables with mesh use among patients of all ages. Childbearing age was included in the secondary analysis as a covariate of interest. 836 females were identified with a median age of 35, 69% were white, with a mean BMI of 32. 14% of patients had a previous hernia repair with a mean hernia width of 2.7 centimeters and a standard deviation of 3.4, and mesh was used in 65% of cases. On multivariable logistic regression, controlling for patient, operative, and hernia specifics, age was not associated with mesh use. However, factors associated with mesh use were ASA classification, BMI, hernia width, infraumbilical hernias, and minimally invasive approach. After we accounted for patient and operative specific characteristics, the predicted probability of mesh use ranged from about 62% for females at aged 18 to 68% for females aged 44, a difference that was not statistically significant. When compared to females aged 45 and older, mesh use was less common in females of childbearing age. However, on multivariable regression, when accounting for patient and hernia-specific variables, there were no significant associations between childbearing status and mesh use. In this study, we found that age was not associated with mesh use when controlling for patient, operative, and hernia-specific variables. These data are an indicator that real-world practice may not be reflective of current evidence to use a suture repair in females of childbearing age if they are still planning on continuing to have children. And this is important as the physiology and the anatomy of the abdominal wall changes during the childbearing process. Further examination is necessary to better understand the patient and surgeon-level factors contributing to decision-making in this understudied population. The findings of our study should be interpreted within the context of their limitations. First, this is an observational study and is subject to selection bias, and causality cannot be drawn. Second, childbearing intent and other obstetrical history cannot be measured from our data set. And finally, mesh use is a patient-sensitive decision, and the clinical decision-making information is not collected in this data set. In conclusion, a majority of women of childbearing age received a mesh repair. However, age was not associated with mesh use. This indicates that real-world practice could possibly be discordant with society recommendations. Further research is needed to identify and better understand the factors contributing to this observed variation in practice. Thank you for your attention, and I'm happy to take any questions.